Good morning. Our lectures today will be about caring of the elderly in the intensive care unit. Okay, one of the difficult, critical, and most important decisions that physician makes is to admit his patient to intensive care or not. Although the intensive care is approved for patients requiring or likely to require advanced respiratory support or requiring support of two or more organ systems. Okay, and this is actually we face, especially with elderly or senior patients, okay, because usually they have comorbidities or many system affected. And patients with chronic impairment of one or more organ system who also require support for an acute reversible failure of another organ. Early referral is practically important. If referral is delayed until the patient's life is clearly at risk, the chances of full recovery are jeopardized. Okay? So that's one of the most important topics in caring of the elderly is caring in the elderly in the ICU unit. Actually, according to the WHO, most of the developed countries have accepted the chronological age of 65 years and above as a definition of elderly or elder persons. Okay, and actually we aiming at the gerontology in studying the scientific study of the biological, psychological, and sociological phenomena associated with old age and aging. Especially that the elderly population are usually exposed to many hazards or many comorbidities and usually have many health problems. And actually, we subdivided the elderly population into three subtypes or subcategories. We classify them from the age of 65 to 75 years as young old, from 75 to 85 years as old, and 85 up to 90 and more as an oldest old senior population or geriatric people. Okay. Actually, the growing number of older adults is placing critical care medicine in a precarious position. The aging demography is already evident in the ICU, where the oldest old, 85 years or older, account for about 20% of the total patients admitted to the intensive care unit. Older adults bring with them complexity and vulnerability not present in many of their younger counterparts. Actually, the vulnerability occurs such as the frailty, the disability, comorbidity are more prevalent with age and increase the risk of adverse outcome. In such cases, these factors overlap, conferring even greater risk. Actually, considering this disease incidence to be a main contributor to healthy lifespan of the elderly population, on that foundational principle of geriatric, because of the decrease on the reserve with aging process, because all systems are affected by the aging, okay, so their capability and capacity to cope with the disease condition or the illness are much decreased with aging process. Okay, actually three factors interact together to have their impact on the outcome on the consideration and determination of the survival and the recovery from any acute illness that may affect the elderly person. These factors are either predisposing factor, okay, which is a pre-existing condition, okay, the precipitating factor, which are the acute illness or injuries, which will affect and leading to acute decline on the health state, okay, on the health level. And the third one, which is the perpetuating factor, or the keep going on factors or condition, okay, as the delirium, the hydrogenic, the immobility, and so on, that prolongs the illness and will prevent or act as an obstacle facing the recovery and complete return to the baseline of the health state. The interaction of these three factors, okay, will determine the survival, the development of impairment and disability, and actual recovery from critical illness. Actually, the critical care provider must be equipped with skills to assess and manage geriatric syndromes like the multimorbidities and multiple associated system affection and chronic disease, the frailty, the delirium, the sensory deficiency, the cognitive impairment, the disabilities, the immobility, the androgenic use, the incontinence, infection. All these geriatric guides or syndromes will have its impact on the outcome from complete recovery, especially when on release from the critical care or the intensive care unit. This can be achieved with in-service training, quality improvement, and design programs and educational program by the International Critical Care Society to improve and elevate the level of providing the care for the elderly population. Who are critically ill patients? Critical illness is any disease process which causes physiological instability, leading to disability and maybe end with death within minutes or hours. And actually, the critically ill patient is one at imminent risk of death. And the severity of illness must be recognized early and appropriate measures taken to assess, diagnose, and manage the illness. Actually, the critical care services can be life-saving, but many patients admitted to the intensive care units are too sick or, conversely, not sick enough to benefit from the intensive care. Especially, it is intense care, it is expensive care, okay? So that the guidelines from the Society of Critical Care prioritize patients for RCU admission based on projected likelihood of benefits from highest to lowest priority. As in priority 1, he is very critically ill, needing intensive treatment and monitoring that cannot be provided outside the ICU. But in priority 2, not critically ill, but requiring close monitoring and potentially immediate intervention. While in priority 3, he is critically ill, but reduced likelihood of recovery because of the underlying disease or severity of the acute illness. And in priority 4, not appropriate for ICU unit, equivalent outcome achievable with non-ICU care. Because of the low risk of clinical deteriorations, presence of irreversible illness, and usually they are the terminal cases, and death is unavoidable. What are the principles of management of critically ill patients? Actually, we have many items that must be covered on management of critically ill geriatric elderly patients. Assign responsibility, initial assessment and resuscitation, focus in our history and do complete comprehensive assessment, perform focus examination and basic investigation, especially with special consideration on elderly immunocompromised patients, Actually assess the response to initial resuscitation and the intensity of the support. Make working diagnosis and the plan of management to improve the outcome and achieve complete recovery. Brief and counsel relatives and make them involved in our plan of management. Actually, the initial assessment and monitoring follow physiological observation should be recorded at the initial assessment as part of the routine monitoring. And the heart rate, the respiratory, all the vital signs is very, very, very important. The systolic blood pressure, the level of consciousness, by Glasgow scale, the oxygen saturation, the temperature, all this must be determined and evaluated for the homeostasis and maximum function of the body and the cells and keeping life. In specific circumstances, additional monitoring should be considered as urine output could be collected hourly, okay, or for 24 hours. The biochemical analysis of some indicators like lactate, the blood glucose, the base deficient, the acid-base balance, the pH. Also, the pain assessment must be evaluated, especially in elderly patients. Actually, the quick SOFA score, which is known as quick SOFA, is a bedside prompt that may be identify patients with suspected infection. The healthcare providers can use it to identify the patient, the incidence of morbidity and mortality among due to sepsis. It assists health providers in estimating the risk of morbidity and mortality due to sepsis. Actually, we can use by doing the quick SOFA score. We based on any two of these three items. If the systolic blood pressure is less than 100 millimeters, the respiratory rate is more than or equal to 22 breaths per minute, and the altered mentation or glycoscales below 15. Score of 2 or more points near the onset of infection associated with a greater risk of death or prolonged ICU stay. Actually, we will take some of the example because we cannot cover all the syndromes that the patient can face on the geriatric patient actually can face on the ICU unit. We will take the hyperthermia, the hypothermia, the nutritional, just an example of these syndromes that may face the elderly people. Human body is a metabolic fluid that generates 1 degree centigrade every hour. And this does not happen due to thermoregulatory system. The elevation or decrease every hour is not happening because of the thermoregulation. The daily variation on the body temperature usually within a range of positive or negative 0.6 degrees centigrade. The heat exchange actually happens through the largest organ in the body, the skin. Body surface acts like a radiator, which discharges excess heat into the surrounding. 90% of this excess heat generated by metabolism, because actually our body is all its system actually undergo metabolism for the activity and vitality. And the remainder extra heat, which is not in need for the body, lost in exhaled gases through the volatile gas. The process by which the body loses heat or exchanges through the radiation, the conduction, the convection, and evaporation. Hyperthermia and fever both indicate an elevated body temperature. But hyperthermia is a result of abnormal temperature regulation, while fever is a result of normal thermoregulatory system operating at a higher set point. In both conditions, the temperature usually exceeds or within 40 degrees centigrade and is called hyperpyrexia. This thermoregulatory is no longer able to maintain a constant body temperature in response to thermal stress, severe exercise, illness, infection, etc. Minor heat-related illness at heat cramps or heat rash, okay, or heat exhausting or heat stroke. All these factors may contribute to the hyperthermia or fever. Actually, heat stroke is a life-threatening condition where the temperature is beyond the 40 degrees centigrade. It may reach up to 41 degrees centigrade. This is a very dangerous degree for the brain, right? Temperature actually for the brain. Severe neurological dysfunction may occur, delirium, ataxia, coma, convulsion, and so on. Okay, and it will have its impact also on the electrolytes, the pH. All of these factors and system of the body will be affected. There will be severe volume depletion with hypotension, and multi-organ may be involved in this case with the heat stroke. Rhabdomyolysis, which is a skeletal muscle injury, the renal failure, the DIC, disseminated marked elevation of serum transaminases, and the inability to produce sweat anhydrosis. It may be a common factor and predisposing, especially in elderly. Also, if there is a severe dehydration, because actually with dehydration there is associated elevation with the body temperature. Actually, myoglobinuria or rhabdomyolysis is a serious syndrome due to direct or indirect muscle injury. It results from the death of muscle fiber and the release of their content into the bloodstream. And this can lead to a serious renal condition and may end in renal failure. Actually, the precipitation of myoglobin in the renal tubules with secondary obstruction, tubular toxicity, or both of them occurring together constitutes the primary causes for acute kidney injury during myoglobinuria. A higher volume of urine flow and a higher urine alkalinity prevent myoglobin from precipitating in the renal tubules actually. The drug-induced hyperthermia is characterized by thermal stress in the interior of the body. The source of this thermal stress is drug-induced, increasing the metabolic heat production. And the hyperthermia syndromes are described are malignant hyperthermia, neuroleptic malignant syndrome, and serotonin syndrome. Actually, malignant hyperthermia is a type of severe reaction that occurs in response to particular medications during general anesthesia. It is uncommon in every 1 in 15,000 of general anesthesia administration may face this condition of malignant hyperthermia or this syndrome. Actually may be related to genetic abnormalities or dominant patterns that may predisposing to such condition. It's actually due to excessive release of calcium from the cytoplasmic reticulum in skeletal muscle, and this may be leading to increased muscle rigidity, high fever, and increase the heart rate, and may end later on in muscle breakdown and high blood potassium or hyperkalemia, which is a fatal condition for the heart. May end in cardiac arrest in diastole. Halogenated inhaled anesthesia as halothane or serofloran or isofloran, okay, actually all this, and also the depolarizing neuromuscular profile as succinylcholine, all this will leading to increase the calcium influx in cytoplasm and uncoupling of oxidative phosphorylation, and marked rise in the metabolic rate. That's why it will predispose to malignant hyperthermia in association with other clinical manifestations. Actually, the management of such condition of malignant hyperthermia is immediately discontinue offending anesthetic agents and the treatment of the muscle rigidity by the dantrolene sodium, which is a muscle relaxant that blocks the release of calcium from the sarcoplasmic reticulum. The treatment may extend up to 3 days to prevent the recurrence. Of course, the side effects may be muscle weakness and hepatocellular injury, and grip defect in the grip strands, okay, and may end in hepatocellular injury and hepatic failure. Actually, special consideration must be taken during caring of the elderly. Like promotion of the self-respect and dignity, promotion of comfort, safety, and that be doing his activity of daily living as much as he can, and all these must be put in the consideration during evaluating the outcome after the release from the ICU, and the movement, the promotion of movement and mobility, and rehabilitation must be initiated as soon as possible so that the elderly patient can regain all his full capacity and capability of performing all his activities. The second example for hypothermia is the serotonin syndrome. Actually, as we know that serotonin is a chemical that the body produces for the nerve cell and the brain, the nerve cell function. But too much serotonin causes silent symptoms, okay, that may range from mild up to severe symptoms, okay, like shivering and diarrhea, muscle rigidity, or fever or convulsion, and severe serotonin production may end in death if untreated condition, okay. The overestimation of serotonin in CNS, as we said, may produce its impact on the mental state, the autonomic hyperactivity, and neuromuscular abnormalities. The list of serotonergic drug producing serotonin syndrome like symptoms may work in combination to produce serotonin. Also, single drug therapy can also result in serotonin syndrome. Actually, most of the drugs involved in serotonin syndrome occurrence are mood enhancer or illegal substance, okay, some medication or drugs. And actually, some of them can produce a neuroleptic malignant syndrome as amphetamine. Actually, these some medications that may have its are capable of producing the serotonin syndrome. Okay, actually مش مطالبين ان احنا نعرف الأدوية أوي، بس ممكن نعرف ان الميكانيزم اوف اكشن بتاعتها بيكون by increase the serotonin synthesis او decrease the breakdown او increase the release او decrease the uptake and removal from the blood. Okay. All these factors may increase the level of serotonin and prolong and magnify its effect. Actually, the serotonin syndrome clinical manifestation or clinical picture may begin after hours of intake of this new medication or the medication that have serotonin-like action. Actually, it may increase the level, it may increase the release, or decrease the reuptake and destruction removal from the body. These symptoms may include confusion, agitation, or restlessness due to autonomic hyperactivity, may lead to hyperthermia, hypertension, and tachycardia, the neuromuscular abnormality as hyperkinesia and hyperactivity, changes on the blood pressure, as we said, and temperature, headache, diarrhea, nausea, vomiting, increasing heart rate, of course, the tremors, shivering, and heavy sweating. Actually, in severe cases, it may be fatal enough to cause death, okay, and may result in high fever, seizures, uncontrollable heartbeat, and maybe a life-threatening condition, and in renal failure, metabolic acidosis, and hypotension. Because of course of the severe activity of the muscle, a high level of acids will be accumulated, so it will affect the pH. And as we know that every 0.5 increase in the pH is accompanied by 0.1 increase in the pH is accompanied by 0.5 increase in the potassium level, which may have its impact on the heart and may result in cardiac arrest or diastole and even death. Actually, the serotonin management is by removing the precipitating drug and stop it, and the management of all associated symptoms, okay, and many cases resolve within 24 hours with proper treatment and medication. But actually, but our bad luck is that serotonergic drug have a long elimination half-life and may produce a prolonged symptomatology. They produce a prolonged. The hyperthermia syndrome is actually decrease in the blood pressure below 35 degrees centigrade. May be due to environmental factor or metabolic disorders as hypothermia, endocrinal as hypothyroidism, therapeutic intervention producing hypothermia. Actually, the adaptation to cold, our body can survive in hotter than cold environment. Okay, the physiological response to decrease in body temperature includes cutaneous vasoconstriction, which will affect the blood supply to all body system, and shivering, which will lead to increased acid accumulation and acidosis. Unfortunately, these adaptations are protective only in mild hypothermia. But in severe cases, it may be threatening to the life and may end in death. Actually, to evaluate the hypothermia that may occur in any elderly person in the ICU unit, we must do the lab tests as the arterial blood gases, the pH of blood gases with serum electrolytes, coagulated states, okay, and the renal function test. Also, serum creatinine level can be evaluated, okay, because to ensure that no rapid meiosis or renal failure. Actually, the geriatric patients who are admitted to the ICU unit and in need of the intensive care, the incidence of increased mortality among them is higher, maybe not due to the effect on the health system or shortage in application of any medical care to them, but actually maybe due to other causes as the occurrence of respiratory failure, the occurrence of many comorbidities of chronic illness, and the severity of this illness. They may be in a very advanced age group, over 89 and over, poor functional state, delirium, infection, sepsis, urinary tract infection. If the creatinine is over 2, the abdomen is below 3, there is severe hypotension, which causes stagnation and it has its impact on the pH. The need for cardiopulmonary resuscitation for more than 15 minutes, and the hematocrit value below 35 milligram per dl. All these factors may have a bad outcome, and the survival rate among elderly is very poor. Actually, after prolonged stay at ICU unit or even in a short stay, we must evaluate the cognitive outcomes, and the cognitive ability of the elderly must be evaluated, okay, to determine the degree of damage or impact on his health state after this admission to the ICU. Actually, delirium is one of the main complications that accompany the prolonged stay outside the ICU unit. It may lead to brain dysfunction, and it is unavoidable outcome of the critical illness. It's a neurological deficiency which is acute, and may complicate the ICU courses of patients, especially with sepsis. And this delirious state will have its impact on the cost and prolonged stay on the ICU. And as we said before, it's very expensive unit of in the hospital. The incidence and the rate of morbidity will be higher. The mortality rate also, and they will need a longer duration to wean from the ventilator, and the incidence of nosocomial pneumonia is very high among them. One of the main parameters that we must take our consideration for the elderly people during their admission on the ICU unit is their nutritional state, where evaluation and assessment of the nutritional state of critically ill patients is very, very important. Either we can do it by the predictive equations or indirect calorimetry for measuring the energy expenditure in critically ill patients, and we can evaluate the high risk of the complication that may be associated with poor nutrition. Actually, an old, frail, elderly, severely ill person must stops taking his caloric needs and the fluids for many days. This may end in coma actually, because of the nutritional nitrogen loss per day will be about 20 to 40 grams. Okay, so that 14 days of starvation is a dangerous depletion of the lean body tissue, okay, and would have its impact on malnutrition is a serious condition among the elderly population. Actually, if is malnutrition for a long period of time, and the elderly person depleted from taking of his caloric need, this may result in confusion, increasing hypothermia, sleeping, incontinence, restlessness, urine output will actually decrease. Okay, and this will decrease the intake of food and fluids by time, so that we must start feeding critically ill patients, okay, within 3 days. His parenteral nutrition must be administered if his health condition is compatible, and allow him to intake his food by his mouth. Otherwise, we can do parenteral feeding, okay, internal feeding. All patients receiving less than their targeted internal feeding after 2 days should be considered for supplementary parenteral feeding. Actually, the composition of the nutrition must have all the essential components as energy from carbohydrates and proteins, lipids, micronutrients, water, and electrolyte to allow a healthy, balanced body. And this will have its impact and will improve the outcome after the prolonged stay or short stay in the ICU or the intensive care unit. At the end, thank you for your attention and the concern, and wish that everything goes actually.